Hi, this is Scott Streckenbach from the Mass General Hospital, and today's lecture is on the perioperative management of implantable cardioverter defibrillators, ICDs. Now, I'm going to make the assumption that most of you have had insufficient training on how to manage ICDs, and I'll also make the assumption that at times it's hard to get someone to help you from the EP lab, from cardiology, particularly at nights and on the weekends. So my objective today is pretty simple. I want to increase your knowledge of ICDs and therefore your comfort and competence and maybe even your enjoyment in managing them. So I'm going to explain how ICDs detect and treat dysrhythmias and how cautery can interfere with these processes. I will talk to you about how to use a magnet. I want you to be a magnet expert when it comes to disabling ICD tachytherapy. I'll briefly go over how to use a chest x-ray for ICD management. I will review briefly as well 4 important ICD management publications that you should probably be aware of. And then I will discuss practical perioperative ICD management, what I do in the operating room on a daily basis. Now, we're going to be talking about 3 types of ICDs. There's the transvenous ICD that most of you are familiar with. It's implanted in the left subclavicular pocket or fossa. There is an RV lead that includes both pacing and sensing electrodes and a shocking coil or 2. There's always a shocking coil in the RV and often a shocking coil in the SVC. Transvenous ICDs also occasionally will have a RA lead, and less frequently, but not rarely, they'll have a coronary sinus lead for biventricular or CRT pacing. So transvenous ICDs can defibrillate, they can cardiovert, they can deliver ATP, and they offer multiple different types of pacing modes. The SICD, subcutaneous ICD, made by Boston Scientific, came out about 10 years ago. The pulse generator is in the left chest wall, the mid-axillary line. You can see that the lead is underneath the skin, just lateral to the sternum. It's a subcutaneous lead, and therefore it requires a little higher energy shock, 80 joules, as opposed to a typical transvenous device, which requires about 40 joules. And it doesn't deliver ATP and really doesn't have much pacing capability other than backup pacing after a shock. The newer device, the extravascular ICD made by Medtronic, it's called the Aurora EV ICD, similarly has the pulse generator in the left chest wall. This lead is a little more sigmoid shaped. It is under the sternum. It's intrathoracic. Because its position's closer to the heart, the shock energy is only 40 joules, and it can deliver ATP. It doesn't provide much for pacing, but a little bit more than the SICD does. Now, it doesn't matter what type of ICD the patient has, whether it's transvenous, sub-Q, or extravascular, which really is intrathoracic. All ICDs sort of detect and treat VF in a similar manner, and I think if you understand how these devices work, it makes it a little easier to decide what to do with the device during the operating room, or when in the operating room. So all ICDs look at RR intervals. They use the RV sensing lead, and the VEG here, the ventricular electrogram, is what the RV sensing lead is detecting. And you can see that the time between 2 R waves is considered an interval, and if that time interval is a normal duration, such if somebody has a heart rate of 60, then that interval would be about a second. ICD's talking milliseconds, so that would be about 1,000 milliseconds. If that interval is normal, the ICD marker channel, which is kind of like the brain of the device, will say, okay, we had a normal interval, VS, all good, V-sense. However, the interval is short. And in this case, if it's less than 320 milliseconds, which is consistent with a heart rate of greater than 187, then the device is going to declare that interval as a VF interval, FS in this case. And if enough FS intervals in the next number of intervals is consistent with VF, and in this case the nominal interval detection is 12 out of 16, then the device is going to declare a VF episode, and the device will then start its charging and then eventually shocking process. Now, how does this actually work in real life? This is an example of a patient who was having a NIPS procedure. We don't do these much anymore, but we basically in the old days would fibrillate patients to make sure that the ICD worked. And so here's an example of ventricular electrogram, normal rhythm. Right here we induce VF with rapid pacing or a shock on a T wave, and you can see these FS intervals here. And in this case, the nominal interval detection is 18 out of 24. So on the 18th FS interval, VF is detected. At that point, the capacitor will start to charge. That takes anywhere from 3 to 5 seconds. And then once the device is charged, most devices are going to take a quick look to make sure that the bad rhythm is still there. It's sort of a reconfirmation of the dysrhythmia, and you can see charge ends here. The device looks and sees VF still occurring, so then the charge is delivered. Now, how long did that take to detect the VF? In this case, with a normal patient, it was about 3.6 seconds, and then the process of charging, etc., takes a little longer. Now, how does the ICD fare in an operating room? So here's an example of a patient having thoracic surgery. The ICD was inadvertently left on. The anti-tachytherapy was left on. And the cautery was essentially continuous here. And you can see the ventricular electrogram is detecting all this cautery noise. And it's calling this noise VF. You can see all these VF intervals. And at this arrowhead here, VF is detected. The asterisks indicate that the ICD is now charging because it believes that the patient's in VFib, even though it's just the cautery doing that. And in this case, it took only about 3 seconds to detect ventricular fibrillation. Now, intermittent cautery can also trigger therapy, and you can see in this case the atrial electrogram, the ventricular electrogram, sinus rhythm here, and then 3 bursts of cautery, and each burst is associated with some VF intervals down here. And then the next page, you see one more burst of cautery, and at this point, the device says, okay, we have detected ventricular fibrillation. We had enough VF intervals, and so now the device thinks that there's a bad rhythm going on. And in this case, as is the case with most ICDs, ATP is delivered quickly as the device is either charging or as, before it starts to charge. And in this case, you see ATP delivered V-pace, V-pace, V-pace. And at the end of the anti-tachy pacing, the device is going to say, all right, did that work? It's going to look at the patient's rhythm, and it sees cautery again. So now VF is detected, and there's no doubt ATP didn't work, so the device starts to charge. Now, this is really interesting. Here's a patient who was in normal sinus rhythm. Cautery-induced ATP, the ATP actually induced ventricular tachycardia. So now the patient really has ventricular tachycardia. You can see the disparity between the atrial rate and the ventricular rate. Thankfully, the device continues to charge. It finishes its charge here and then delivers a 41 joule shock here. Now, this occurred during an endoscopic procedure where the team didn't think that the ICD needed to be suspended. They never noticed the shock, and they never noticed the ATP. So what are the key concepts to take home from these few examples? Continuous or intermittent electrocautery can quickly trigger ICD treatment protocols. Only 2 to 4 seconds of cautery are needed to trigger therapy, and therapy can include cardioversion, ATP, and defibrillation. Now, anesthesiologists often use a magnet to suspend the anti-tachytherapy to prevent situations like I've just described. And what I want to do is make sure that you are all experts at using a magnet in the operating room when you need to do so. This chart summarizes, it's a very up-to-date and comprehensive summary of how a magnet affects ICDs from each of these manufacturers. Now, I'm not going to go into detail about this chart, but I'm going to cover 6 things that you should know as an anesthesiologist to effectively use a magnet in the operating room. And the first thing you need to know how to do is how to put the magnet on the ICD to turn off the anti-tachytherapy. This seems relatively straightforward. You're just supposed to put the magnet on the device, but unfortunately it's not quite so simple. Abbott St. Jude recommends that the magnet be placed on one side or the other of the housing. This is the header and this is the housing, and so on one side or the other for Abbott. Biotronic says to put the magnet such that it's slightly above the top of the housing, sort of opening up a little bit of a window to the header. I'm going to just show you this slide to make this a little bit more obvious. This is Biotronic's technical support manual. The header is on the top, and then the housing, which is where all the circuitry is and the capacitor and the battery and so on, is below. And what Biotronic says is to put the magnet in such a manner so that the magnet's opening covers a little bit of the header as opposed to being right in the center of the housing. Boston Scientific transvenous ICDs, Medtronic transvenous ICDs, and Microport ICDs just require the magnet to be over the center of the housing. Pretty straightforward for those. If you have a patient who has an SICD from Boston Scientific and it's a current device, the magnet should be placed over the bottom of the device or over the header of the device. If it's an older device, then you should put the magnet right over the center of the housing of the Boston Scientific ICD. And if the patient has an EV ICD by Medtronic, the Aurora, then the company says is to put the magnet right over the center of the housing, just like its recommendation for a transvenous Medtronic ICD. Now, you're probably saying to yourself, what the heck is with all this variability in the manufacturer's recommendations for magnet positioning? I can't give you a definitive answer, but I can give you some concepts here. 3 important magnet principles. Magnets suspend the anti-tachytherapy by activating a reed switch or a Hall sensor that's implanted within the housing of the ICD. The position of this activating sensor varies among the manufacturers, and it's not easily determined by people like me. The magnetic field of a ring magnet is maximal on the inner and outer edges. It's minimal in the center. And what does this mean? Well, here's the standard magnet we use. The magnetic field is a toroid shape structure. There's no significant magnetic effect in the center of it. The predominant magnetic effects are on the inner and the outer part of this toroid. And so what we have to do is put the magnet into the location that the manufacturers recommend, presumably because they know better where that reed switch or that Hall sensor is located in the ICD. Now, you may be thinking, does it really matter where we put the magnet? And the answer, unfortunately, is it does. And this is one of the several case reports that describe this problem. This case demonstrates the possibility for error when relying on a magnet to suspend tachytherapies. This is a patient who was having an ileostomy reversal, had an Abbott ICD, so this is a lower abdominal procedure. The magnet was placed centrally over the ICD to suspend the anti-tachytherapy, and they put the magnet on before they put the patient to sleep. Shortly after induction, real VF occurred. Now, the ICDs were about to take off the magnet to let the ICD do the shocking, but before they even got the magnet off, the ICD shocked the patient. And the reason this happened is because the magnet was not in the right position. When they looked at the records, they could see that the anti-tachytherapy was going on and off because the magnet was moving ever so slightly and inhibiting and then not inhibiting the anti-tachytherapy. This is another case where a patient was having oral surgery, again, Abbott ICD. The rep in this case advised placing the magnet directly over the ICD to disable the anti-tachytherapy. In other words, didn't tell the team to put it on one side or the other. Shortly after monopolar cautery use, sudden movement is noted. The anesthesiologists were a little worried that might have been the ICD, so they convinced the surgeon to use bipolar cautery for the remainder of the procedure. And post-procedure, they revealed 1 ATP, 1 shock, and 2 aborted shocks. So clearly, the magnet was not appropriately positioned in this case either. Now, interesting, a quote from that paper, the second paper, regarding the subtle and somewhat vague description of how to place a magnet. It says if such small variations of magnet placement could in fact be responsible for the failure of the ICD inactivation, then magnet placement should not be considered a viable option. Now, I pretty much agree with this comment. So the take-home messages about magnet positioning is place the magnet according to the manufacturer guidelines, using this limited knowledge of magnet physics and your limited ability to identify the ICD orientation, right? So, you can look at the chest x-ray to see how the device is sitting in the patient's chest. You can see where the header is and where the housing is. Sometimes you can appreciate it by manual palpation, but sometimes not. So it's a little hard to know exactly where you're putting the magnet relative to the housing and the header. So I just sort of, you have to try to use your best judgment. Now, the really important thing is recognize that magnets may fail to suspend the anti-tachytherapy if their magnetic fields are not close enough to the ICD's reed switch or the Hall sensor. Now, if we assume that the magnet has been positioned appropriately, can we assume that the ICD is always going to respond to the magnet? Well, although rarely the case, Boston Scientific and Abbott ICDs can actually be programmed to ignore a magnet. Now, if you look at this is an Abbott programmer report, and the typical magnet response would say normal, but the programmer can change the magnet response to ignore. Same thing is true with Boston Scientific. You can see here magnet response inhibit therapy, and in this case, magnet response off. So this is a small problem, but what you might ask yourself, what happens if somebody uses a magnet in a situation where the device is not going to respond to a magnet? And the answer is pretty straightforward. It's you generate a case report. And Pete Schulman and Mark Rosner published this quite a long time ago, but there are other reports like this. These patients in their paper, 2 of them had Boston Scientific ICDs that had unknowingly been programmed to ignore a magnet. One because the magnet was affecting the patient at work, magnetic field was. And so in one of these patients, 20 shocks were delivered, 12 rounds of ATP were delivered, and the battery was completely depleted during the operation. So, take-home message, Boston Scientific and Abbott ICDs can be programmed to ignore a magnet. Thankfully, this is incredibly rare, but if you want to know for certain, you can confirm the programming with the patient's electrophysiologist or request an interrogation. Now, concept number 3 is a little more straightforward. What does the magnet do to the anti-tachytherapy? This is quite straightforward, in fact. It suspends the anti-tachytherapy. No matter what device you have now, is assuming that it's programmed to respond to the magnet, the anti-tachytherapy will be inhibited for as long as the magnet is on the ICD. If you remove the magnet, then the anti-tachytherapy will always be reactivated. There's only one thing to remember, one caveat, is if you are using a magnet to suspend the anti-tachytherapy of a biotronic ICD, the ICD will automatically reactivate after 8 hours of magnet use. If you want to continue to use a magnet in a procedure that's going past 8 hours, you need to remove the magnet about 3 feet away for about 30 seconds, and then you can put it back on and get another 8 hours of inhibition. Number 4 is also pretty straightforward. What does the magnet do to the ICD's pacemaker component? Now, if you think about a pacemaker, not an ICD, if you think about a pacemaker and you put a magnet on it, 99.5% of the time, the pacemaker is going to pace at an asynchronous, mode at a manufacturer-specific rate. 85 for Medtronic, 90 for Biotronic, 98 for Abbott, and 100 for Boston Scientific. ICDs are different. When you put a magnet on an ICD, if you have a Medtronic, Abbott, Boston Scientific, or Biotronic ICD, which is what 99.8% of the devices are in this country, then the magnet will not affect any change in the pacemaker mode or rate. So what that means is if you want to change the patient's pacing mode of an ICD, you can't do so with a magnet. You have to use a programmer to change the rate, to change it from DDD to DOO, whatever, okay? Number 5, what tone is emitted from an ICD when a magnet is applied? This is an important one to know. The answer's a little more complicated than you'd like to hear. Boston Scientific, there are 3 possible responses. Medtronic, 3 possible responses. Abbott, 2 possible responses. And then Biotronic and Microport do not emit a tone when a magnet is placed. So let's talk about them. Boston Scientific ICDs, the typical response, the normal response, will be a beeping tone that's either every second or R-wave synchronous that lasts as long as the magnet is in proper position for transvenous ICDs. If you put a magnet on the Boston Scientific S-ICD, the beeping will actually stop after 60 seconds, but the anti-tachytherapy continues to be suspended as long as you haven't moved the magnet. The second potential response of a Boston Scientific ICD with respect to a magnet is a monotone. And what this means is if you put a magnet on the Boston Scientific ICD, instead of that beeping tone, you will hear a continual tone, like a beep. What this indicates is that somebody has already turned off the anti-tachytherapy of that Boston Scientific ICD. And this happens in our scenario where if somebody turns off the anti-tachytherapy upstairs before the patient comes down to the operating room, and the nurse doesn't tell us about that, we then put a magnet on the ICD and we hear this monotone. The other response that a Boston Scientific ICD can have to a magnet is no tone. And this can happen in one of 2 scenarios. It can happen if the ICD is programmed to ignore the magnet. That's pretty straightforward. The other potential is that the speaker function could have been disabled due to MRI exposure. And this affects any Boston Scientific ICD that was made prior to, I think, around February 2022. And you're probably thinking, well, how the heck are you supposed to know this? Well, it will tell you on the programmer report that the beeper has been disabled due to MRI protection mode usage. Now, the good news is that since February 2022, Boston Scientific ICDs are now refractory to this injury caused by an MRI. And if you look at a new program report, you'll see down here, it says beeper type. I'm going to just zoom in and point out what this says. It says the piezoelectric beeper is designed to withstand the strong magnetic fields associated with MRI scanners without being damaged. So this won't happen if you have a new Boston Scientific ICD, but you could have no tone when you put a magnet on to older Boston Scientific ICDs. And even though there's no tone, the ICD is technically being suspended, assuming you're placing the magnet in the right position, which is for Boston Scientific right over the center of the housing. And what does the standard tone sound like? And so this tone, which actually sounds like a sat probe, is present for as long as the magnet is on the device. And it's sometimes a little hard to hear, so if you put a stethoscope right over the magnet, you'll hear it very, very well. And just as a reminder, the SICD emits the same tone, but only for 60 seconds. What about Medtronic? Medtronic, the typical response is a monotone that lasts for about 10 seconds. It starts as soon as the magnet is in the proper position, and it continues for, like I said, about 10 seconds. It indicates, number one, that you've positioned the magnet in the right place, and it indicates that the device has no alerts. You might hear an on-off tone, which is beep, 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 for 10 seconds, and that tells you that there's some clinical alert or a device issue. And you can also hear a high-low tone for 10 seconds that would also indicate a clinical alert or a device issue. The tones can be programmed, these on-off or high-low tones can be programmed by whatever the EP doctor decides is what is the way it's programmed. And so for some patients who don't hear this on-off tone because they have poor hearing, they might use the high-low tone. And so the bottom line, if you hear one of these tones, you know something's not quite right, and you should probably try to get somebody to interrogate the device. If it's an elective procedure before you start the case, or if it's an emergent procedure, do it after the patient's had the procedure. Now, what does the Medtronic normal tone sound like? That's the Sept probe. Okay, so you can hear that the tone stops even though the magnet is not moved. It just lasts for about 10 seconds. This is one example of a patient who's got a clinical alert or a device issue. This is the high-low tone. It sounds a little bit like you're in Paris and there's a policeman coming by. So the next one to talk about is Abbott St. Jude, and for the most part, most of these devices, Abbott devices, don't emit a tone, but the last two devices made, thankfully, the Galant and the Entrant models, there is a 4-second monotone emitted upon magnet application and then a 6-second higher-pitched monotone upon magnet removal. Now this is contrasted with all other Abbott ICDs which do not emit a tone. This one's a little hard to hear, unfortunately. Hopefully you'll hear it, but you'll hear a low pitch monotone for 4 seconds or 6 seconds, and then a longer one for a higher pitch tone for 6 seconds. Okay, now it's interesting because regarding this tone stuff, somebody wrote, Gary Rourke, who's a very well-known EP anesthesiologist, he wrote, in my opinion, the lack of a continuous indication of suspension of tachyarrhythmia therapy from an ICD is a design flaw and represents another argument for reprogramming an ICD instead of applying a magnet. So it is a little frustrating that there's variability in the tones emitted and that many of the devices, most of the devices, quite frankly, other than Boston Scientific, don't emit a continuous tone to let you know that your magnet is in the right spot. So it's not too surprising when I give you the answer to the sixth question, do magnets reliably inhibit the ICD? And the answer is not always. And it's particularly the case when patients are in the lateral or prone position, patients who are obese, patients where the surgical site is near the ICD. So this is an example of a patient who's having thoracic procedure. He's in the lateral position. Patient has a transvenous ICD, and the anesthesiologist put a magnet on the ICD hoping to suspend the anti-tachytherapy. During the procedure, here's the ventricular electrogram. You can see a lot of cautery starting right here. You see a lot of VF and F intervals on the bottom, on the marker channel. The next page, you see some more F intervals, and then finally VF is detected. The asterisks, again, indicate that the capacitor is starting to charge. Remember, the capacitor charges for about 5 to 10 to 15 seconds, depending on the battery life and the charge requirement. And that, once that's done, the device is going to reconfirm that the rhythm is still abnormal. You can see at the end of charging here with the asterisk N, the device looks and sees that the rhythm now is normal, so the shock is aborted. So here's a patient who was, wasn't in VF. The ICD was inappropriately or inadvertently still on. The anti-tachytherapy, the device detected the cautery as if it were VF, charged, but then it aborted. And so the question is this benign? And the answer is no. The ICD charging diminishes battery life even when the charge is not delivered. A full charge may consume as much as 30 to 46 days of the ICD's battery life. Same patient, 30 seconds later, cautery again detected by the device. You can see all the VF intervals here. Then a big pause from the cautery, and then next page, a few more VF intervals, and then VF is detected. In this case, because the device had already charged, the capacitor was holding a lot of charge, the shock was delivered quite quickly, and you can see a 30 joule shock was delivered here. Now, why is this so bad? Why is it bad that the patient got a shock? Well, this is probably obvious, but unnecessary shocks can initiate VF. Shocks are bad for the heart. One of the reasons that we stopped doing NIPS procedures to test whether an ICD was going to do what it was supposed to do was because they found that shocks, every shock, causes a slight diminution in cardiac function. Obviously, if this happened to an awake patient, the patient would be shocked and obviously mad. Shocks can also move the patient dangerously if the patient's not fully relaxed with muscle relaxants. This is particularly a problem if the surgery it's a delicate procedure, or if the patient's head is in pins and so on. So here's an example of a patient who was in the prone position, head in pins, had an Abbott ICD, the magnet response was enabled according to the preoperative evaluation. A magnet was carefully placed on the ICD and secured with multiple tegaderms by an anesthesiologist. During the case, the patient was fully relaxed with neuromuscular blockers. Post-op assessment revealed 11 rounds of ATP, 19 shocks delivered, 29 aborted shocks, and the battery life was reduced from 5.5 to 3.8 years. Magnets may also fail in obese patients. This is an example of a patient who is having ECT, a 49-year-old patient. Abbott ICD, anesthesia team used a magnet to suspend the anti-tachytherapy, and an 8-second ECT stimulus was delivered. And you can see that the ECT stimulus starts here. The ventricular electrogram senses it. The marker channel quickly detects VF intervals, and within 2 seconds, VF is detected. The next page, you can see 25 joule shock is delivered just before the ECT stimulus ends. Magnets may fail when surgery is near the ICD. This is thyroid surgery, and the patient had a biotronic ICD. A magnet was used to inhibit the tachytherapy, and this was a post-operative assessment. Again, the patient received 2 shocks during this procedure. Now, this to me is really potentially dangerous because, when they're doing thyroid surgery, they're close to the vagus nerve, and an inadvertent shock in somebody who's oftentimes not completely paralyzed could be devastating. Magnets may fail, when the surgery is near the ICD. Here's an example of a patient having a TAVR, Boston Scientific ICD. The magnet was positioned, and they thought it was turning off the anti-tachytherapy. And right here you see the rapid pacing that's initiated that we do when we do TAVRs. Initially, the rate is detected as V-sense, but then it goes to VT, and then finally VF. And enough VF intervals are detected here. And again, what most ICDs do is they deliver anti-tachytherapy to try to break the rhythm, or they do it while they're charging. And you can see V-pace, V-pace, V-pace here. This is the anti-tachytherapy being delivered. And so you basically have anti-tachytherapy pacing and external pacing. So you have 2 pacing spikes firing in this interval here. Once the ATP stops, the device looks and sees this high rate still, so it starts to charge. And then just before the external pacing is stopped by the anesthesiologist, a shock had been delivered, a 36 joule shock had been delivered. This is an example of somebody who's in a supine position but has an SICD. Magnet's not your friend for SICDs when the patient's supine. This is a very interesting case. A patient having a heart-kidney transplant had an emblem, Boston Scientific ICD. The magnet was, the speaker was fine. The team tried to reprogram the ICD, but the programmer, for some reason, was not communicating with the ICD. So they placed a magnet, but they never heard any beeping tone, and they just attributed it to being a noisy OR. They didn't try to use a stethoscope. Again, the patient was supine. And after cross-clamper removal, the patient had VF. 3 external shocks were given, but there were also 3 unexpected chest wall movements. Post-operative interrogation revealed 3 ICD shocks were delivered. The team was not sure if the magnet was initially positioned appropriately, or was the magnet put on appropriately initially, and then it had moved due to gravity and maybe the spreader opening up the chest and so on. The take-home message from this paper was magnet deactivation of SICDs is less reliable than for transvenous ICDs and should only be used in emergencies with careful consideration of intricacies of magnet use. So the concept here, I think, that you'd want to take home is that magnets are not so reliable. In most of these cases, the anesthesiologist didn't even know that the shocks had occurred. They were detected in postoperative assessments, postoperative interrogations. And I suspect that this happens a lot more often than we would like to think. Now, we love to use magnets because they're easy to use. If the patient develops a dysrhythmia, we can just remove the magnet and let the ICD do the job. And there's no risk of ever sending a patient home with the ICD still off when we use a magnet. The downsides, as I mentioned, there's a small one, skin necrosis from prolonged pressure, but the big issue is the magnet will fail to actually suspend the anti-tachytherapy. Now, the ultimate sort of most reliable way to avoid the risk associated with using a magnet is to use a programmer to suspend the ICD's anti-tachytherapy. Now, of course, that, even though it's 100% reliable, it does require somebody with programmer training. That usually is the EP doctor or cardiologist. But in some centers, including at Mass General, anesthesiologists have learned how to use these programmers. And I will tell you that it's relatively easy to learn how to suspend the anti-tachytherapy certainly for 3 of these devices, for the Boston Scientific, the Abbott, and the Biotronic devices. The Medtronic device is a little bit harder to turn off the anti-tachytherapy, but again, eminently easy to learn. Now, of course, there's risks associated with using a programmer, and I don't want you to think that that's the perfect solution. But there's always the risk that if you turn off an ICD with a programmer, if the person who's in the room taking care of the patient doesn't know how to treat the VF because they don't know how to use the defibrillator, or if there's no defibrillator available immediately, then that can be a major problem. The bigger issue that I worry about is the sending patients home without turning the ICD back on. So you turn it off pre-op and you forget to turn it off post-op. Now I turn a ton of devices off, and I've implemented multiple ways to prevent somebody from going home. And one of the ways is when we first developed or started using Epic, I had my office mate who was in charge of Epic for our hospital to create a reminder. So if I disable an ICD, it automatically puts a note up here into the chart to re-enable the ICD. Same thing with pacemakers and so on. All right, so a lot of magnet information. Now let's shift to something that's a little easier, how to use the chest x-ray. Now, sometimes a patient will come in at night. You'll know that there's a device there, but you really just don't know what it is. If you have a chest x-ray, you can differentiate a pacemaker from an ICD pretty easily. You'll notice on the left there's a pacemaker. You see the pulse generator, the leads, there's the sensing and pacing electrodes at the end of it. But the ICD has the shocking coils that are not going to be present on a pacemaker. So if you see a shocking coil, 1 or 2 of them, you know your patient has an ICD. And as shocking coils are represented here, this is the actual lead. You can see this, the RV and the SVC leads in real life represented by these I'm about to say hyperechoic, but the really bright chest x-ray signals. You can tell I'm an echocardiographer too. And then the one other thing is, it's hard to appreciate this, but the ICD the pulse generator is always going to be bigger than the pacemaker pulse generator because the ICD has to have a capacitor in addition to the battery, whereas the pacemaker only has the battery. Now, you can also differentiate a standard ICD from a CRT device, cardiac resynchronization therapy. This is a patient with a CRT device. You can see the shocking coils, which tells you it's an ICD. And if you look carefully, you can see the quadrupolar coronary sinus lead as well. And sometimes it's easier to see it in the lateral film. You can see that this posteriorly positioned quadrupolar coronary sinus lead And if you think about echocardiography again, the coronary sinus is a posterior structure, and so this lead being in the back of the heart makes sense that it's a CRT pacing lead. Now, if you have a patient who has a Boston Scientific SICD, the pulse generator is going to be on the lateral chest wall, and then the lead, again, is relatively straight right in the middle of the chest, just a little bit lateral actually to the sternum. If you look on the lateral film, it's a little easier to see that this is a sub-Q device and not a intrathoracic device, which when you look at the Medtronic Aurora, you see it. The big thing that differentiates the Aurora from the SICD, the easiest thing is to look at the sigmoid-shaped lead that the Medtronic Aurora has. And I put this chest X-ray on purpose because if you don't get a good wide view of the patient's chest, you might miss this pulse generator on the patient's side. So, if you see something like that, at least go looking for something over here. Now, if you're not sure whether this is a Aurora EV-ICD or a SICD, just look at the lateral film and you can see how this is below the sternum, intrathoracic, as opposed to over here, which would have been the case with the SICD. And if you look at these two back to back or side to side, you can see the straight for SICD and you can see the E-shaped for the EV-ICD. Now, it's also easy to determine what type of ICD the patient has, what the manufacturer is. And the manufacturer is important to know because you want to know what to expect when you put a magnet on the device in terms of the tone. It's also important to know the manufacturer if you want somebody to come and interrogate your device, because you have to use that manufacturer's device, the programmer. You can't use a Boston Scientific programmer for an Abbott device. Now, if you look at any X-ray and you zoom in on the device, you're going to see a alphanumeric indicator. In this case, for Abbott, it's SJM, and it's oftentimes backwards for some reason. If you look at Biotronic, you'll see the sort of a little ET-shaped, ET on there, but also this looks like a little Mrs. Pac-Man or Mr. Pac-Man. Let's see. Medtronic looks like an upside down or a horseshoe, and Boston Scientific has either BSC or BOS with a number. Now, you don't have to necessarily look for those alphanumeric indicators anymore. You can just use the Pacemaker ID app, which is free. You just load it on your phone. You zoom in on the chest X-ray so you can get a good picture. You put the crosshairs around the ICD, push the green button, and it'll give you a very reliable report of what type of ICD the patient has. It works really, really well. It works for pacemakers, obviously, as well as ICDs. All right, now let's shift to the 4 society publications that you should at least be aware of, and ideally, if you're interested in this topic, you should read. They are the HRS, Heart Rhythm Society, ASA Expert Consensus Statement, 2011, the ASA Practice Advisory Update 2020, the British Heart Rhythm Society Guidelines from 2022, and the AHA Scientific Statement on Care for Patients with CIEDs that was published last year. The Heart Rhythm Society ASA Consensus Statement it's an excellent review of perioperative electrophysiology. It provides guidance for all types of procedures, but it was written predominantly by cardiologists. There were 2 anesthesiologists on this paper, Mark Rosner and Anne-Marie Thompson, and so it's a cardiology-based paper. That's good and it's bad, and we'll talk a little bit about that in a second. The ASA Practice Advisory, which was updated in 2020, was obviously just anesthesiologists. In fact, there were just 2 anesthesiologists writing this paper, about 3. And this is a better paper because it comes from the anesthesia perspective. It provides perioperative guidance for all types of procedures, including an excellent MRI section. I always tell people, if you're going to read this, just read the appendix, but also the footnotes in the appendix. You'll get more than the gist of the paper with a lot less effort than reading all of the standard guidelines papers. In 2022, the British Heart Rhythm Society Guidelines were published again. This is primarily written by cardiologists, but it does provide a very useful definition of pacemaker dependency, which I think is a good thing to know. Covers loop recorders, insertable cardiac monitors, and remote monitoring nicely. And the best thing about this is it has a helpful chart on how to manage ICDs and pacemakers in the OR. And so if you look at table 1 of this paper, on the side you see the type of surgery, so surgery above the umbilicus, surgery below the umbilicus, cardiac surgery, etc. And then you see on the top pacemaker management and those that are pacing dependent and not dependent, and then ICD management and those that are pacer dependent and not dependent. And so, for example, if you have a patient who's having endoscopy and the patient has an ICD but is not pacer dependent, it tells you to deactivate the ICD if diathermy or argon is anticipated, or apply a magnet. So I really think that this could be a helpful diagram for most of you to have access to when you're taking care of patients. The last paper was the 2024 AHA scientific statement on management of patients with ICDs. This provides the best coverage of any of them on leadless pacemakers and the newer ICDs, not surprisingly. It has an excellent section on EMI CIED interactions in various OR environments, sort of like the Heart Rhythm Society paper had. And it also has a really nice section on chest x-rays. It shows you chest x-rays of all the different types of devices, leadless devices, implantable cardiac monitors, pacemakers, ICDs, and so on. All right, so that's sort of all the background knowledge. We've talked about how ICDs detect and treat dysrhythmias. We talked about how cautery can interfere with that. We've talked in great deal about how magnets work. We've talked a little bit about chest x-rays, and then we've talked about some guidelines that you could read to learn more about how to manage these devices. And so now we'll just talk for the next 10 minutes or so on perioperative ICD management, and we'll specifically focus on pre-op and intra-op and post-operative periods. Now, the preoperative period is almost always the most important. You want to assess the patient's device, and when you assess the patient's device, if you follow the Heart Rhythm Society guidelines, you will get that. Make sure that the device is interrogated within 6 months. The 2024 AHA scientific statement said you should interrogate an ICD within 3 months of an elective procedure. 3 months is the time that we use at Mass General. It's probably better to do 3 months than 6, but you got some support either way. Now, obviously, if the patient has some symptom or sign that's indicating possible ICD dysfunction, you'd want to get the ICD interrogated immediately preoperatively rather than just 6 months ago. The other thing that you want to do in terms of preoperative assessment is, in terms of the patient's device, is you want to obtain the pertinent device information, how it's programmed. And this is directly from the HRS consensus statement. So basically, it's cardiologists, for the most part, telling us as anesthesiologists that the best prescription for perioperative management is for the EP team to communicate pertinent device information to the OR team, i.e. us. What's that information? Well, this table summarizes all the information that the cardiologists think we should know, what we should get from the patient's cardiologist or electrophysiologist. Now, that's a lot of information. I'm obviously not going to go over that, but I will tell you that if you look at the preoperative evaluation form that I've given to you, you will see essentially the most important information that you need to obtain. This is the information that I want to get when I'm taking care of patients at Mass General. The type of the device, the manufacturer, where the device is implanted, when was the last interrogation, is the patient pacemaker dependent or not, is the battery and lead okay, or battery and leads okay, and then I want to know the current settings of the pacemaker, what's the mode and what's the rate. I also want to know the ICD treatment zones. Now, all of these things are probably pretty straightforward to you, but the ICD treatment zones might be something that you don't typically look for. It's not critical, but I will say that it's sometimes helpful. And this is an example of a patient who has a Boston Scientific ICD, and you can see that the treatment zones are as follows. So if the heart rate exceeds 200, that's going to be considered VF. There'll be ATP delivered and then 8 41 joule shocks. VT will be detected if the heart rate is greater than 160 and less than 200. And again, ATP is delivered and then eventually shocks as well. Now, you might think, do I need to know what the specific anti-tachy treatment parameters are? And as I said, in some cases, it can help if you know that. And this is a case report that I reviewed this year. It's published in ANA Practice. The team was taking care of a patient who had a Medtronic ICD. The patient was having a TAVR. The magnet was used to suspend the anti-tachytherapy. The patient was paced at 180 for deployment, to implant or inflate the valve. After deployment, the patient actually had unstable VT at 159, at a rate of 159. So the pacing that they did for the procedures would precipitate the VT. Now, again, the patient has a magnet on the ICD, and so what the team did is they took the magnet off, and they were sort of hoping that the ICD would treat the unstable VT. And they waited for 15 to 30 seconds. No shock was delivered. So then they kind of got a little nervous, and they delivered a asynchronous 360 joule shock, which unfortunately precipitated actual VF. Now, as they were sort of getting ready to shock that patient again, the patient's ICD shocked the patient and converted the patient back to sinus rhythm. And the problem here was that the patient's VT zone was 162 to 222. So the patient's actual VT rate in the OR that day was 159 and was therefore below the VT treatment zone. And so the ICD wasn't going to do anything about that. Only when the patient went into VF did the ICD actually see something it needed to treat, and then it treated it. And so the take-home message here is I think it's useful to know the ICD's treatment parameters when you're going to use a magnet to suspend the anti-tachytherapy, particularly if the patient has a history of ventricular tachycardia. Now, the second thing we have to do with preoperative management, so the first thing we did is we want to find out as much as we can about the patient's device, when it was last interrogated, what the settings are. And then this is where anesthesiologists actually are really, really good. We know the surgical situation better than the cardiologist. We know, is cautery going to be required? What type of cautery is it? Can bipolar cautery be used as opposed to monopolar cautery? What's the patient's position going to be? Is a magnet going to be an option? Where's the surgical site? Is the surgical site right next to where I'm going to put my magnet? And therefore I wouldn't have access to the device. And how long is the surgery? If the surgery is going to be 12 hours, you have a sick patient, you might not want to leave a magnet for 12 hours in someone's skin. And so when you integrate the information about the device with the surgical plan, then you have to come up with what you're going to do with the device. And there are really three options. You can just leave the device alone, the ICD that is. You can suspend the anti-tachytherapy, or you can suspend the anti-tachytherapy and reprogram the pacemaker. So if you have a patient who's having thoracic surgery and the patient's pacemaker dependent, then you have to not only turn off the anti-tachytherapy, but you probably need to convert the pacemaker to asynchronous. So if you decide to just suspend anti-tachytherapy, you have two options. You can use a magnet, or you can reprogram the ICD. If you have to suspend the anti-tachytherapy and reprogram the pacemaker, you have one choice. You have to reprogram that ICD. You can't use a magnet because remember, a magnet does not have any impact on the pacemaker component of an ICD. Now, when you're trying to figure out what to do, there are going to be two key questions. One, when should you suspend the anti-tachytherapy? And the answer to that one is unfortunately relatively complicated, and many of you probably already appreciate this. So if you look at the 2011 HRS ASA consensus statement, which hasn't been updated, but it is a really good paper, it says that if there's surgery above the umbilicus, inhibit the ICD. It says if surgery is below the umbilicus, oversensing in an ICD patient is unlikely when monopolar electrosurgery is applied below the umbilicus. And then it says may be unnecessary to inhibit an ICD with a magnet or a programmer, but it is a reasonable alternative to no intervention. In other words, it's telling us if the surgery is below the umbilicus, it doesn't say you don't have to suspend the anti-tachytherapy. It's saying it's an option. Okay. Now, with respect to surgery on the lower extremities, it says the risk of false arrhythmia detection is considered so low for surgical procedures on the lower extremities that neither reprogramming nor magnet application is mandatory. And what does the ASA practice advisory say? It says that if electrocautery is going to occur for surgery that's planned above the umbilicus, suspend the ICD's anti-tachytherapy. It does not, and I repeat, does not say anything about what to do when surgery is below the umbilicus. How about the British Heart Rhythm Society guidelines in 2022? Well, in addition to saying if the surgery is above the umbilicus, inhibit anti-tachytherapy, it also does say something about surgery below the umbilicus. It says that it's reasonable not to deactivate the ICD in this scenario. And then if you look at sort of the three zones, where you have the zone where it's above the umbilicus, below the umbilicus, and then lower extremity surgery, for the zone 1, it's crystal clear, turn off the anti-tachytherapy. For zone 2, may be unnecessary to deactivate the anti-tachytherapy, or reasonable not to deactivate the anti-tachytherapy. Basically, there's a little bit of support here that you don't necessarily have to turn off the anti-tachytherapy. You can potentially leave it on according to the HRS paper and also according to the British Heart Rhythm Guidelines. Lower extremity surgery, you have this quote from the HRS document: neither reprogramming nor magnet application is mandatory. So, what evidence supports these recommendations? There are not too many papers, unfortunately. This was in 2017, Mayo Clinic. 103 patients having non-cardiac surgery, and the ICDs were programmed to detect only bovary return pad was placed on a thigh or a buttock. 11 patients had bipolar cautery, and not surprisingly, no issue. The patients who had monopolar cautery, 92 of them, 11 had EMI detected, and this is sort of how it looked. The patients who were having surgery above the umbilicus, so in the head, shoulder, upper arm, thoracic, and abdominal procedures, they had, that's where the ICDs were detecting dysrhythmias, detecting the cautery as if it were dysrhythmias. But you can see that for hip or lower extremity surgery, 24 patients, none of them had any detection of the cautery by the ICD. And so this paper sort of supports not suspending anti-tachytherapy for lower extremity surgery. Now, this is a bigger paper. This was Peter Schulman's group, and they looked at 144 patients who had ICDs having surgery on various parts of the body, and they also sort of turned off the anti-tachytherapy treatment, but they kept on the sensing of the Boston Scientific Medtronic ICDs in this study. They used a very specific protocol for dispersive pad placement, in other words, the bovary return pad. And this is a very good paper, even if you're just reading it for general EP issues, for example, pacemaker management, because this protocol is very useful to keep cautery noise away from the ICD's sensing electrode. And so, for example, if the patient's having surgery on the left knee, the cautery return pad is placed on the back of the left thigh to minimize where this cautery stream is going. Same thing as if you have a patient who's having right arm surgery here, put the bovary return pad or the dispersive electrode in the posterior ipsilateral shoulder so that the cautery stream stays on the right side and doesn't go near the RV sensing leads. When they did this, not surprisingly, 68% of the patients who were having heart surgery, the EMI was detected. For surgery above the umbilicus, which was about 20%, or 70% of their patients, 20% had EMI detected. And then for patients who were having surgery below the umbilicus, only one person, 2.5% of the patients, had EMI detected. And in the paper, they said that the EMI that was detected wasn't enough to be clinically meaningful. Now, the summary from this paper was that it suggests that we may not need to suspend ICD therapies when surgery is below the umbilicus. And so these are the two papers that are sort of out there, and then there's a lot of experiential knowledge that went into the publication's recommendations. But one thing that's really important to understand is that you have to pay attention to bovary return pad placement. Nurses are not typically going to know that the relationship between a patient getting a shock and the bovary return pad placement. And so this is a perfect example of why it's important. In Northwestern University, I think this was just 2 years ago, a patient was having a left hip arthroplasty had a ICD in the left chest, standard position. The return electrode was placed on the patient's back at the level of the umbilicus. No magnet was used, and they said, following the ASA practice advisory, which I think, hopefully if you remember what I said, that's sort of a misuse of the recommendations of that ASA practice advisory. The patient had 9 shocks and 4 rounds of ATP. The battery life decreased from 5.5 to 4 years. And so that's a pretty significant decrement in the battery life. This is another case where patient was having a right knee procedure, spinal anesthesia. He's a little on the short side. Cautery return pad placed on the contralateral leg. Anesthesia team acted in accordance with HRS ASA consensus paper, which is true, and they did not inhibit the ICD. I was asked to review this paper, and I basically, I think the patient got a shock. Patient also had a round of ATP and 7 aborted shocks, which we talked about earlier is not benign. I think it's either because the device was on the contralateral leg and possibly because the patient was so short. If you have a short patient, the distance between the RV sensing lead and where that cautery stream is probably not it's definitely not as much as it is for somebody who's 6 feet. The other thing to think about is to be aware of the underbody dispersive electrode system. Now, I don't know if you use the Megadyne here, but it's being used more and more. It incorporates the Bovie return pad into this pad that the patient lies on. And so in a typical patient, the cautery stream can be minimized depending on where you put the Bovie return pad. But with the Megadyne system, if the cautery is applied here, it's dispersed throughout this large electrode that the patient is lying on, and it's much easier for the ICD to sense that cautery. And not surprisingly, there have been multiple case reports of patients getting shocked who've had an ICD left on in the setting of a Megadyne underbody dispersive electrode. This paper described 2 patients having lower extremity procedures, one getting 7 shocks and 2 ATP, and the other getting 3 shocks and 3 ATP. All right, so what's the verdict with all this information I'm throwing at you? Number 1, surgery above the umbilicus, it's crystal clear, suspend the anti-tachytherapy. Number 2, if the Megadyne system is used, suspend anti-tachytherapy. If surgery is below the umbilicus, there's modest support for not suspending the anti-tachytherapy. If the surgery is on the lower extremities, there's stronger support to not suspend the anti-tachytherapy. However, to guarantee that the patient's not shocked, or if you just want to be ultra-conservative, suspend the anti-tachytherapy even for surgeries on the lower extremities. My practice, given that I have my own programmers, I suspend just about every ICD as I don't want to take any chance of any unintended shocks or unrecognized battery depletion. All right, so the second question you have to think about when you're trying to figure out what you're going to do in the OR is, if you decide that you're going to turn off the patient's anti-tachytherapy, what are you going to use? Are you going to use a programmer or a magnet? I would suggest that you use a programmer to suspend the anti-tachytherapy if you need to modify the patient's pacemaker settings. That's pretty straightforward, right? That you have to do that. If you're not sure how the ICD is going to respond to a magnet, I recommend a programmer. If gravity may displace that magnet, programmer. If surgery will preclude easy access to the ICD, such as thyroid surgery or heart surgery, I would suggest a programmer. If the ICD is difficult to palpate, patient's obese, or there's a recent implant so they have a dressing on it, your magnet's not going to be reliably in position, use a programmer to turn off the anti-tachytherapy. If there's concern for magnet-related tissue necrosis in a really kicked old patient, use a programmer. And then lastly, if you just cannot take a chance that the patient will get shocked, the patient's having a very delicate procedure, the patient's going to be wide awake, whatever. Now, if you would rather use a magnet, and there are some benefits to use a magnet as we talked about, as long as you know how that device is going to respond to the magnet and that you have good access to the device, and and gravity is not your enemy, use a magnet if there's no access to a programmer. Now, if you have no access to a programmer, you're having a choice. You're going to have to use a magnet. But if you you might want to minimize interventions, you don't want to have to call somebody to turn off the ICD before and then turn it back on after, then a magnet is a great choice for that situation. A magnet's great if you're worried about external defibrillating capability of the people who are going to be in the room while the patient's under anesthesia. If you don't have somebody that you can reliably count on to defibrillate the patient, you don't happen to have a defibrillator immediately available, then a magnet is the best way to go. And if you don't want to take any chance of the patient being discharged with the anti-tachytherapy off, again, a magnet is a good way to go. If it's no problem turning it off, but at the end of the case, in the middle of the night, you're worried that the patient's not going to get the device turned back on. It's going to be the weekend. You're just worried that the patient's going to get sent home without the anti-tachytherapy being turned back on, then a magnet is a good choice for that situation. All right, now what about intraoperative management? We talked about the preoperative management. That's where the big, that's the big decisions to be made. But intraop, there are a couple things to think about too. You always want to make sure that the patient's continuously monitored once you turn off an ICD. So if you turn off the ICD in the pre-op area, you got to make sure the patient's monitored and has a defibrillating mechanism immediately available. I never turn off an ICD myself unless there are R2 pads connected to a defibrillator, and I can confirm whoever's going to be with that patient can show me how to use that defibrillator effectively. And that was what I kind of just said, backup defibrillation, pacing capability. Strategic electrocautery return pad placement. I would highly recommend reading Peter Schulman's paper on the best way to put the dispersive electrode on your patient and use that no matter whether you're using the patient as an ICD or a pacemaker. I would ask the surgeon to deploy the lowest effective cautery output, because even if you've turned off the anti-tachytherapy, you don't want the pacemaker component to be interfered with if you hadn't converted it to an asynchronous pacing mode. Watch for inappropriate shocks, which obviously aren't going to be present if the patient's fully relaxed. Watch for ATP on the ECG or any other pacemaker dysfunction that you think is related to EMI. Now, if you are going to use a magnet, what I recommend is try to figure out where the header is in the housing. And you can see here I did a little drawing around this patient device. I think I used the chest x-ray to confirm my hypothesis that the header was up here and then a housing down here. Put the magnet on and make sure that you solidify it or keep it in place with a large tegaderm or clear tape. And then you want to monitor that magnet position frequently, every 5 to 10 minutes, just to make sure it hasn't moved. And if you happen to have a patient with a Boston Scientific ICD, you can actually put a stethoscope on it and hear it pretty easily, that continual beeping tone that you would want to hear. Now, in the intraoperative situation, there are two scenarios that I think you should at least think about ahead of time. If you assume you have a patient, you've used a magnet to inhibit the ICD, and you have R2 pads on to emergently defibrillate the patient if necessary. What will you do if a patient develops VF? Okay, so you have the magnet on, the patient develops VF. You have two choices. You can remove the magnet and let the ICD do the shock, or you can just shock the patient with the external defibrillatory pads. Now, either choice is reasonable, but I just want to make sure that you understand this concept. If you choose to take the magnet off the ICD and let it do the shock, it's going to take a couple of seconds for you to move from where you are to take the magnet off. It'll take about 3 or 4 seconds probably for the ICD to detect the VF. Then it will take anywhere from 5 to 6 up to 15 seconds for the capacitor to charge, and then maybe another half second to reconfirm the dysrhythmia, and then finally the shock will be delivered. And so you might have a 15 to 20 second delay from the time that everybody sees that the patient's in VF and you take the magnet off before the ICD will actually deliver the shock. So if you're willing to wait that long while everybody's looking at you, sort of saying, do you know what the hell you're doing? Then go ahead and take the magnet off and do the shock. What I typically would do in this scenario is I want to shock that patient immediately. I probably would take the magnet off, but I'd also defibrillate with the external defibrillatory pads. I wouldn't wait that 15 to 20 seconds, and I would just shock the patient. Another scenario is where a patient develops VT, and we talked a little bit about this in one of those case reports. You have two choices. Again, you can remove the magnet and let the ICD manage, or you can shock the patient with external defibrillatory pads. Now, because ATP is quite effective, assuming that the hemodynamics allow it, and you know that the VT rate exceeds the ICD's cutoff rate, I would remove the magnet and let the ICD try to break that VT with ATP first, obviating the need for a shock. Obviously, if the APT doesn't work, the device will shock the patient as well. Or if at any point you just feel like I got to get rid of this right away, you can just do an external defibrillatory shock, preferably R-wave synchronous, as opposed to just an asynchronous shock, and then having the risk of causing VF. All right, we're almost done. I know this is a lot of information. Postoperative management. There are 3 possible scenarios if you look at the HRS ASA consensus statement, and you should read this part of the paper. For patients having high-risk procedures or high-risk situations, the ICD should be interrogated prior to the patient being discharged from a monitored setting. And you're probably thinking, well, what the heck is a high-risk procedure? Well, if there are not 8 things listed in the HRS ASA consensus statement, patient or pacer was the IC or pacer was reprogrammed pre-op. The patient underwent cardiac, thoracic, or a open vascular procedure. Patient had a cardiac arrest, cardioversion, CPR. Patient had emergency surgery above the umbilicus and you didn't have time to interrogate the device ahead of time. If the patient had radio frequency ablation or therapeutic radiation. If a shock or unexpected movement was noted. If abnormal tones were emitted from the ICD, or there was apparent pacemaker dysfunction, or you had to place a PA catheter or a venous drainage line into a patient who had an ICD that had leads that were less than 3 months old. In all those scenarios, interrogate the patient's device before the patient leaves the PACU or the ICU. Now, this list comes directly from the HRS ASA consensus statement. Now, you don't have to go look for it there. If you look at the back of my preoperative evaluation form that you should have all received, you can see all of those indications on the back of the on this preoperative evaluation form under the postoperative management recommendations. Now, the second scenario is where a patient had monopolar cautery use or lithotripsy. In that scenario, you should tell the patient to have the ICD interrogated within 1 month of discharge from the hospital, and that can be either in person at the cardiologist's office or via telemetry. This also is listed in the heart rhythm ASA consensus statement, and you can see, for example, here monopole electrosurgery, ICD evaluated within one month from the procedure, unless Table 9 criteria are fulfilled, which are the criteria that we just talked about earlier. And then the last scenario is where no cautery was used, no lithotripsy. Just tell the patients to get their routine EP follow-up. So pretty straightforward, I think, for postoperative management, unlike the intraoperative and the pre-op management. All right, so final review. Number 1, it takes 2 to 4 seconds of cautery to fool an ICD into believing a patient is in VF. Intermittent cautery does not prevent shocks. Inappropriate shocks are bad, and even aborted charges deplete the battery significantly. Magnets inhibit an ICD's anti-tachytherapy, but magnets do not affect the ICD's pacemaker component. A chest x-ray can help you determine what type of device your patient has, and so can a magnet if you use your knowledge of the tones that are emitted. Preoperative ICD interrogation should be within 3 to 6 months of the surgery. Inhibit anti-tachytherapy if surgery includes cautery above the umbilicus. Pay close attention to the cautery return pad placement. Magnets may be unreliable for prone or lateral patients, for obese patients, and for surgeries close to the ICD. Programmers are very useful. Consider learning how to use them. And lastly, if you turn off your patient's ICD, you become that patient's ICD. Thank you for your attention. If you take a picture of this icon, you'll get all of the papers that the 4 consensus papers and a couple of the other papers that I talked about during this talk. And then you can use my website at any time. That you don't have to sign up for anything. You just go in there, and there are 22 lectures, which includes the lecture you're hearing today. If you have any questions or concerns, please email me. I learn by people complaining about what I said or disagreeing with what I said. So have a great day, and thank you.